Dr. Patricia Pinto is here with us as well. And I wanted to give her the opportunity to give greetings. She represents, I guess, the physicians in Portugal. And she's a physician that has come into this work recently, but with a lot of vigor. And so, Dra. Patricia Pinto, would you kindly dar umas palavras de abertura e bem-vindas, faz favor.
Good afternoon to all. It's a great pleasure to be in this meeting and this first meeting. Today is the National Day for EM in Portugal and in the world. And I think our major goal now is to develop the knowledge in medical, in doctors, in nurses, all the medical staff in Portugal, because I work here in Portugal and this is my country, and especially because this disease for me as a rheumatologist is not a new disease, but in fact is being more each day that passes we have more patients that we can give them the diagnosis and especially give them a word of hope and about all the things that are being done, or the medical advice that we can give them, and all the science reports and investigation that is being done. What should I say else? Of course, this disease is a very disabled disease. It's most of our patients that have the disease for more than 1 year or more than 10 years, they know what they suffer. They suffer because sometimes they don't find the right medical advice. And this, for me, in my country, in Portugal, and I think in all over the world, should be a major concern, that our doctors, our nurses, everyone that works with this disease or has patients that can mimetize this disease should have the knowledge of the disease and what represents in the clinical features, the lab results that we will not find, the immunological features that are not typical or will make this diagnosis, and especially what we can give these patients as an advice, a medical advice, a support advice, so that they can live better. Of course, just to finish, I think in Portugal now we still have to do a long work, but I think that each time we speak about the disease, someone will listen and we will have more doctors, nurses, and all the medical staff with the knowledge of this disease and with the better information to give them. So this is our besides giving the best support to our patients, this for us is very important. For me, is very important. So I hope that next year we will have more information and more good news for our patients, and especially with this disease, that it will be better known all over the world and especially in Portugal. So thank you very much.
Thank you, Dr. Pinto. Many of the items that you talk about, many of the challenges we're going to be exploring in this series.
Yeah.
For this particular one, Dr. Levine suggested that we focus on how to carry out a proper clinical interview.
Yeah.
And from the stories that I've heard from many of the patients here in Portugal, when they go to physicians don't know about the illness, and if they have some inkling, the clinical interviews that they give are very, very superficial.
Yeah.
So what we're going to do is we're going to do a role play. I have ME. I got sick in 2016. And eventually, through trials and tribulations, I was able to find proper doctors. And amongst them, Dr. Levine, I'm her patient. I have been her patient now for 5 years. So I know what it was like not to be attended properly. and then what it took to actually find someone that understood the illness and could begin treatment. So we're going to do a bit of a role play around doing a clinical history. Over to you, Dr. Levine.
Mm-hmm. Thank you very much, and nice to meet you, Dr. Pinto. Yes, so Joan, tell me a little bit about any previous medical conditions that you had prior to the onset of your ME, and these would include, in particular, irritable bowel syndrome, sinus issues, chronic sinus infections, migraine headaches, and if you'd been in any type of serious accident, like an automobile or other type of accident prior to getting ME.
I was diagnosed with fibromyalgia when I was 40. And so that was something that I was living with now for 16 years, but had been able to manage quite.
Right. And was it relatively easier, I guess, compared to your journey with ME/CFS to get the fibromyalgia diagnosis?
Yes, my primary care physician was a pioneer among primary care physicians. And actually, she was one of the physicians that had advocated for the CDC recognizing fibromyalgia and everything. So I was very fortunate in that sense because I was immediately, I diagnosed, taken seriously. I was given a gradual exercise program. They focused on, overcoming the fear of pain and getting on with your life. And I went to, I had physical therapy done by extraordinary people. And, within 3 months, I was back. I was able to go back to work. And using mind-body approaches so that I wouldn't end up taking a lot of the heavy the heavy drugs. In addition to the fibromyalgia, I did have migraines. I developed the IBS afterwards. Autoimmune, no other autoimmune, just asthma. Not even asthma, allergies to dust, but very minimal allergies. And other than that, I was very healthy. I had Meniere's as well, which in retrospect could have been a manifestation of my immune system not being able to handle the herpes virus, but yeah.
So one of the things, just as an aside, that we're looking at epidemiologically is determining if there are risk factors, at least clinically, that would better, keep us on the lookout for the development of something like this. And then let me just sidetrack one other question that I hadn't prepped you for, Joan. Family history. Mom, dad, or siblings have any autoimmune, allergy, migraine, or POTS-like conditions? Like first-degree relatives. Go ahead.
Since I became diagnosed, my brother also was diagnosed a year and a half after me. He also had a lot of what appeared to be sinus infections, but in reality they weren't. That he was treated for sinus complications, but it was doctors that really didn't understand what was going on. And me, like him, we had low-grade fevers. Onset of the final viral infection that did us in. Low-grade fevers, and I had very frequent respiratory infections as a result of travel as well. So there was something going on, even before that.
I think that's important to try to highlight. Of course, there's so many questions that need to be asked. Now, describe for me, if you would, the circumstances surrounding the onset of your ME, and it sounds, well, you'll tell me if it's acute versus gradual, because there are two possible types of onset. But go ahead.
I got sick. I know I got sick on July 6th of 2016. I remember the day. And previous to that, I had been in the last 2 months, I'd visited like 5 countries, gone to 2 cities in the US. I traveled a lot. I traveled in areas where, for the World Bank project, these were slum upgrading projects. So these are projects in areas where there was no sanitation, no latrine, no waters. So when I returned to the US, I returned on a Friday. And that Monday, the 6th was, I believe, a Monday. All of a sudden I got very sick. And I thought it was a respiratory problem, but I didn't know if I had caught something. And then on July 6th, I tried to get out of bed And that's when I realized that something really seriously was wrong with me, because I had had bronchitis before, I'd had community-acquired pneumonia before, but this was on a very different level, very different level. So I went to see emergency care doctors who put me on steroids, and my oxygen was low. I managed the viral pneumonia at home. But then there were certain symptoms of it that just never went away. And so 2 weeks, 4 weeks, 6 weeks, 8 weeks, 10 weeks, at 12 weeks, a whole new set of symptoms surfaced. The crushing fatigue, the inability to be in a room with light, inability to be in any environment with any kind of noise. I mean, sometimes even the sheets, the rustling of the bed sheets was too much. Sensory overload from that.
Right.
The insomnia, just horrible insomnia. So then a whole series of other symptoms came in. But I remember it was July 6th of 2016.
Yes, frequently that's etched in people's minds, you know. Now, so you describe a very classic presentation there, and I'll take this opportunity to hallmark the clinical presentation. 3 major symptoms, all of which Joan has described here: post-exertional malaise, unrefreshing sleep, and cognitive issues. You didn't say, you didn't speak to that yet, but I'm going to ask you, did you, needless to say, did you have trouble remembering the names of people, or do you felt like you had to do, and maybe even now, one thing at a time? You can't multitask.
Yeah, the cognitive issues didn't come in straight away. I had like the cognitive issues that you have when you have the flu or something, you know, that you're slow thinking.
Yeah.
But I was on conference calls and everything. But then after a couple of months, I was no longer able to do that. I couldn't read anymore. I couldn't. I would get lost in my house, going to the bathroom, like I wouldn't know where I was going.
And meanwhile, let
Just
me bring out the fact that at this point, you still didn't have a real diagnosis yet. The
no,
doctors were just saying, oh, this is just a prolonged, right, flu-like illness, or, yeah.
right, they didn't know what it was, and they were pumping me up with steroids. And so 5 months in, I decided to speak with some tropical medicine specialists, because I figured maybe I caught something that the US physicians don't know about, you know, because of my travels.
Yes.
So
Mm-hmm.
the person who referred me to the chronic fatigue syndrome clinic at Stanford was my former mentor and boss, who was the professor of tropical medicine, and had been the professor of two of the Stanford specialists that are big names in this field, who happen to be Colombian, Jose Montoya, Gilberto Montoya, and Hector Bonilla. So at 8 months in, I went to see them. I was very fortunate, because some people wait years. I got in at 8 months. But when I went to see Dr. Montoya, you know, he gave me the diagnosis, and then he told me to stop doing everything that my primary care physician told me to do, which was to try and exercise. All throughout the time that I was sick, even with a fever, I was being told that I had to walk and I had to swim. I used to get in the car, drive to the pool, and have to rest for half an hour. Then I would walk into the swimming pool and have to rest for 15 minutes. Then I would have to put on my swimsuit and rest for 15 minutes. I would go in the water for 15 minutes. Then I'd have to stop for like, you know, an hour to get
Mm-hmm.
dressed. It used to take 5 hours to do. And then I got progressively worse. I got a point where I couldn't get out of bed anymore. So at 8 months, that's when I got
Yeah.
my diagnosis.
Yes, yes. And at that point, Joan, would you describe that you had not only fatigue, but post-exertional fatigue as well?
Oh yeah, no, it was bone crushing, and yeah, I mean, fatigue on a level that it's hard to fathom, and we really need different words, because fatigue, it's like Eskimos have 100 words for snow, and we don't have 100 words for fatigue, and we really should, because there
Yeah.
are different types of fatigue, and this was something that was just really,
Were
it's
there
hard.
times in the beginning or even during the course of your journey with this illness where you had to, like, get dressed in stages, for instance, or
Always.
even you would delay taking a bath, a shower, or use a shower chair if that, you know,
Yeah, no, I mean, I would,
these activities of daily living? Yeah.
almost embarrassing to say this publicly, but so
Right.
it was in really kind of just like a survival mode.
Right.
And yes, getting dressed. Well, first of all, what I did was I couldn't stand a lot of the fabrics. I had to buy all new clothes because just the touch of fabrics was just horrific. So I just
Yes.
bought things that I could sleep and if I needed to go outside in, I could go outside without looking too silly, you know.
Okay.
So to minimize changes of clothes and stuff like that.
And let me just bring up another issue, which may not be, or it probably is important in other countries, but obviously you had to grapple with your job, which was like a large part of your identity. You were someone who was highly skilled professional, and you had to grapple with, I suppose, what to tell your employer, how to file for disability, meanwhile, your primary care doctor perhaps may not have been that supportive, because it sounds like she might have felt like you were just going to get better with exercise and so forth. Was that a difficult moment for you too, having to make that decision without that much support? Yeah.
That was very difficult, and Dr. Bonilla was very frank with me. He said, the activities that you've done in the first few months have seriously reduced the likelihood that you're going to be able to bounce back from this, because instead of resting, you've gone into I was going into constant up and down crashes one after another, trying to keep up with what this physician told me. So he said, now you have to just lie still, and so that meant when I went back to my work, I had to tell my
Right.
employer that it didn't look good, and so they better start replacing me with teams. That was very, very, very difficult.
And you would have wished that you had a primary care doctor who had known you for so long. Do you feel like your primary care doctor in a way let you down by even not by not having to know that much about it as much as a specialist, but kind of not doing some legwork to try to find more options for you and possibly partnering with a specialist?
Totally. And when I went to see Stanford, she dismissed them. She said, "Oh, these people are going to confine you. You're going to get locked into a sick patient dynamic where you see yourself as sick, and you're going to become deconditioned. And so you're gonna, you're just never going to get out of bed, and you're going to be useless," with what she said. But it would have been very helpful to have a doctor that was familiar. And I think here, and I think this is also true in Portugal, I've heard from many folks, is that the fibromyalgia community has done a good job. Nowhere near where it should, because it's still an illness that is, untreated. But people will rapidly move to, I think, identify some folks that have ME as fibromyalgia, and they propose these things. And even on the advocacy websites of the patient organizations, up until last year, graded exercise therapy and CBT was still being pushed.
Right.
So you really have to understand that while there are comorbidities, and for me, I have both of them that were identified by top specialists. You have to have a nuanced approach. And I think for us, and Dr. Patricia Pinto, I think, mentioned this, the importance of having all kinds of doctors, primary care physicians, general medicine, family medicine, as well as specialists, have a preliminary understanding of this.
And some para health professionals, like you say, physical therapy or occupational, because for instance, I get referrals from physical therapists who recognize that this person has more than fibromyalgia or along those lines. And then, now in terms of describing your current set of symptoms, at about approximately on the average, at what threshold do you feel, after what type of physical exertion or what amount of physical exertion will you know that you're going to crash? And have you made it a point to, limit, to sort of parcel out your energy stores, so to speak?
Yeah, pacing has been, probably the most important tool, because if you don't pace, even if you take the drugs, it's not going to help. But pacing plus the targeted medications have made a very big difference. I guess you learn to listen to your body, and it can be hard sometimes. So today I'm going to have this conversation with you. That will be my long conversation for the day. I can't do more.
Yes,
I can't
that's
go to
right.
I can't go to family outings where there are many people, because it's too much stimuli. I can't, Christmases, all those things I can't do. because the events are too long, will eventually give out.
Right.
Uh,
Well, I'm glad you brought that up, because I think people just associate it with physical fatigue, but I think that overstimulation is such a, unfortunately, a deterrent.
And also,
Yeah.
I talk too much, which I probably do anyway. No, but if I talk too long, after a while, I find it difficult to breathe too. It becomes harder and harder to breathe. Sometimes I start coughing. Physically, I can now stand and I can be on my feet, which I couldn't before I took the Mestinon.
Right.
So
Let
I
me,
can.
yeah, let me just summarize just very shortly. So post-exertional malaise, the unrefreshing sleep, and the cognitive issues we discussed, those are the IOM reports, clinical criteria. They're kind of succinct, but I think they really encapsulate what most physicians would need to know to diagnose a patient in a limited amount of time that they might have for an office visit. The rest, I call it icing, but important icing, like finding out about the occurrence of sore throats, gland swelling, and so forth. And then, Joan, talk to me a little bit about the visit with Dr. Systrom and the evaluation you had with him.
So after about a year and a half, I got to see you, Dr. Levine, and then you had recommended I reach out to Dr. Systrom, so I did. I went to see him and I got the invasive cardiopulmonary exercise test done, and so that showed that I had preload failure, which was really magnificent because
explain what that is in layman's terms.
Gosh, I wish I could, but essentially my heart isn't producing enough oxygen, right? I think
There
that's
you go. And it's beating too quickly sometimes when you stand, right? Yeah.
And so sometimes not even when you stand, sometimes it's when I would turn in bed even. So that was very important because Dr. Systrom told me you're not deconditioned. This is the reason why you can't stand, why you have all of these difficulties. And so that was very important. And I sent that to my primary care physician, and so he also did a small fiber neuropathy test. And then I took part in his early clinical trials for the Mestinon. He was relatively new to ME at that point. He didn't have that many patients.
Yes.
So the Mestinon turned out to be just really
Yes.
and the low dose naltrexone, which you put me on. I also went to see a psychiatrist to be able to elucidate what cognitive functions I had lost and which ones I had retained. And that was very important too. It was at your recommendation. And this doctor was also someone who had developed the malingering scales that are used in psychology. And for those of you who don't know what the Malingering scales are, these are scales that are introduced in usual tests that people do, cognitive or other, to be able to determine whether or not you're faking.
Validity. Yeah.
So when I had that ICPET, which by the way, as a result of the conference, is now finally being offered in Portugal.
Terrific. Yeah.
Some of the people here on the conference call that will be carrying out that ICPET in Porto as a result of that, and the neuropsychiatric evaluation, and of course all of the other tests that I did.
Right. But I do want to just say 2 words about that, if I may. So that's great about the testing. Sometimes the clinician, even in a very crude way, can determine the presence of orthostatic intolerance, which is what we call the dissociation between blood pressure and pulse when a person changes position, by just doing a simple, what's called a NASA test, where the patient sits and then stands, and you see the vast rise in pulse rate, which is abnormal. And the reason I want to emphasize that is that if you fix that, quote unquote, like Joan did with Mestinon, by improving blood volume, you get more blood flow and oxygenation to the brain, and the fatigue improves. And you get the patient feeling, oh, there's some hope here, some response. So that's an easy one to do, a low hanging fruit. And the other one, which maybe we'll touch on briefly, is mast cell activation. So mast cell activation means that there's sort of a hyperinflamed feeling in your body, and the immune system is on fire, so to speak, and secretes these molecules, histamine and tryptase. That's another important target for treatment. That is something that one can determine from a blood test. But to get back to some of your other symptoms, do you have, so aside from the orthostatic intolerance, you can also get gastromotility. Do you get symptoms like that where you can't eat, only eat small meals?
That's right. Or sometimes I have intolerance to certain foods, and then sometimes that goes away. I had always intolerance to alcohol, but I was never much of a drinker, so I didn't know if it was whatever. But so certain foods, and then interstitial cystitis, the bladder problem.
Yes.
And I went to a gynecologist here in Portugal who didn't know what that was, and she wanted to do all kinds of aggressive testing. It was very difficult. So
I find that, I mean, it's important for I think even the primary care doctor to be able to identify some of these comorbidities, because you can really help the patient a lot if you determine that they have gastric dysmotility, like you say, the interstitial cystitis, pelvic floor dysfunction. Endometriosis is another common thing that's associated with this as a possible risk factor. Small fiber neuropathy. So when you were talking before about the skin biopsy, small fiber neuropathy is where the immune system literally attacks your central nervous system. Do you find like you get numbness or tingling of your arms and legs at times, or where even the blanket touching your skin is uncomfortable?
Yeah, clothes touching. It comes and goes, but yeah, the tingling is always a problem. Sometimes it's worse than others, and then cramps, like really bad cramps.
Right. And did you, during the course of this, get a sleep study as well?
I did get a sleep study, and I didn't have sleep apnea. I had some kind of sleep disturbance, but the test didn't show it. So I actually asked for 2 sleep studies. I said, I have a sleep problem. You have to find it. So I did a second one. And they didn't find anything.
They didn't find anything. Did you have an MRI of the brain or of the cervical spine?
No,
of the neck? No.
I was going to, but then COVID came in, and I never did.
I just bring that up because that's part of a more of a differential diagnosis. So really, you pretty much know when the patient walks in and they've seen a dozen doctors that they likely have ME/CFS. But I only bring that up about the MRI is that there's some diseases that you want to make sure that we rule out, like multiple sclerosis, and the other one that I've seen sometimes overlapping is adrenal insufficiency. So you want to test cortisol levels, and some other hormonal tests I think are important to know about. But I want to emphasize to the clinicians out there that these 3 major symptoms are very important in terms of diagnosing 90% of your patients with ME, but that you shouldn't just stop there, that you should keep reevaluating your patient for the possibility that maybe you have missed something. But by the same token, move in the direction of trying to treat their ME/CFS, if that makes any sense. So tell me a little bit about some of the initial treatments that you received for your ME.
Before I got my diagnosis, I tried everything. I tried acupuncture with this very venerable doctor who was a very famous acupuncturist and also a doctor in Western medicine. And he told me finally that the acupuncture was harming me. It was the inflammation. It was horrible. So I tried, and then he had tried me Chinese herbs. I tried those. I went to a Mind Body Institute. These were all what my primary care physician was, and I was getting worse and worse and worse.
Yes.
The acupuncture in particular was really terrible. I mean, it was.
Yeah.
Finally, it was so painful too. And this guy was an eminent and very skilled person, so it wasn't,
Right.
What else?
And then, so when you finally got to Dr. Montoya or Dr. Bonilla, did they start you right away on the antiviral treatment?
Yeah, the antiviral treatment, and then they have a protocol of different supplements to try, some turmeric. One special thing that I liked was 1 square of dark chocolate every day.
That's a good one.
I would have 4 instead of 1. Perhaps that wasn't so good. So different medications, different supplements. And then the fact that someone could actually herd me.
Right. Okay.
When I finished the visit with Dr. Bonilla, his former my former boss, who was his mentor and the dean of his medical school, told me, I want you to call me, tell me how my student did. So I did. So I called him up, and he said, I just have one question. And I said, okay, what was the question, Dr. Guerrero? He goes, did he listen to you? And I said, yes, he really listened. He goes, excellent, I have no more questions. So I thought, that sounds really silly, but it really isn't. I mean,
You're absolutely right. I think that's the heart of it. Yeah.
Did he
In an
listen?
illness where there are no definitive answers, that's the most important thing.
That's right. And so he took a very, comprehensive history and like Dr. Patricia Pinto says, you have a doctor who can at least recognize for this for what it is and potentially start giving you hope. Or if no hope, at least that you feel validated.
Absolutely. Yeah, no, I think that's definitely the pathway. And it takes the burden off the patient that they're, because you're being questioned all over the place. And then somebody just with some authority just listens in a respectful way. I guess
think part of the reason why eventually I was able to get the disability and have doctors finally take notice was because many of the doctors that had diagnosed me were very eminent physicians. So nobody in the field was going to challenge them. If I hadn't had recourse to these specialists, my story would have been very different. And I know this is the story that many people in the US and all over the place, where even the physicians who side with patients, and I don't know if this has happened to you, Dr. Levine, but I know it with many, many doctors that I've known on unknown tropical diseases, if they involved in an illness that's poorly understood and they become too not friendly, but they take almost like an advocate stance, that they become targets of people in their own community saying like, what are you doing? You shouldn't be doing this. This isn't a real disease, or you should be focusing more on, diseases that will further your career, where there's money, where there's pharmaceuticals, where there's, so right. I was very fortunate.
Yes, yeah, love me, and still don't. But, my colleagues have come to respect me a little bit more than when I first started out. They did ask me in the beginning, why are you doing this? But I think as time goes on, they're relieved to have someone knowledgeable about it. Some of them still don't want to take on the burden themselves of diagnosing or treating it, though. That's still kind of a challenge. But it's an interesting thing culturally how that works.
When I arrived in Portugal, I found a primary care physician, but who didn't know much about it, and he studied about it. And then finally, he fired me. He said, "I think you should go to someone else because I'm too old, and this is too complicated, and I don't think I can do it justice. So you need to find another doctor."
Oh boy,
something else.
Yeah. Well, I think, again, not to get, I want to really focus on your symptoms, but I think it's important to also bring out the fact that I try to also refer people to the appropriate cardiologist, neurologist, or other specialists that can treat better than I can. I can identify, but I can't really in-depth treat some of the comorbid disorders. And we touched on a lot of them. The few, I think especially important are the cardiologists with the POTS, and then the neurologist possibly with small fiber neuropathy. But there's others so there's also predisposition to other autoimmune diseases like Sjogren's syndrome and rheumatoid arthritis. So to have a good rheumatologist on board, I think is important as well, because you want to be able to cast a wide net and follow these comorbidities over time. The other quick thing I'll mention is there's been some metabolic changes in a lot of the patients where there's a higher risk of cardiovascular disease, we believe, in people with ME, because the cholesterol slowly rises and the insulin levels rise because the body is in hypometabolic energy conserved state. So you want to kind of just be aware of some of those things. I'm just saying that. So, and then the other quick thing I wanted to clarify, when Joan says with the antiviral, we're talking about targeted against Epstein-Barr and human herpes virus 6, which we think are the culprits in a large proportion of patients with ME. And that's why I guess Dr. Bonilla put you on an antiviral in particular, like an Valtrex or Valganciclovir. Now, and then the Mestinon, which is a drug that Dr. Systrom put you on, targets the vascular imbalance or the, and regulates that again and allows more blood flow to flow evenly to different organs of the body. And so I just wanted to say that. And then, do you also get temperature dysregulation yourself? In other words, do you find yourself either sweating excessively or freezing cold suddenly out of the blue?
Yes, and it can all take place within an hour. Yes, and then if I'm under a lot of stress, as
Sure.
well. So it's very odd.
Yeah, yeah. And so we divide treatments into those for symptomatic relief and those that are more targeted at the virus and with the blood pressure we were just discussing. Do you find that you have to take a sleep aid, something to help you sleep?
I try not to because I don't want to get a dependence on them, but then sometimes I will have periods when I feel worse. It's like a domino effect. When you feel worse, all the symptoms come back. And then you have to fight to get each one back under control. So when that happens, I do take sleep aids. But as soon as I can, I try and practice good sleep hygiene so that I can get off of them because I don't want to become dependent. Also because over time they'll stop working. So yeah, I take them when I need to. When I'm very, 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 very tired or very, very relapsed with a post-exertional malaise, it doesn't much matter if I take handfuls of those pills, they won't work. They work when I'm slightly, slightly sicker. When I'm way sicker, there's no point in taking any of those drugs because none of them are going to work. So you just write them out.
Do you find too, just a couple more questions, that I actually don't recall whether you got COVID on top of this, but if you get COVID or another viral infection back, in other words, do you feel like you're much more vulnerable and less, resistant?
I haven't gotten COVID. I do get sometimes colds, and I've had some flu-like things. And yes, it does take time. Before it used to be just a week tops. Now it might take 2, 3, 4 weeks, and then the symptoms go away, and then the body's still tired. So,
Right.
so to get back to your old normal, your old.
And have you had problems with things like dental procedures or other types of interventions? Some of the patients worry about getting anesthetics or, anything like that, or preparation for colonoscopy. People are actually concerned about the prep for the colonoscopy.
No, I had referred pain. I sometimes all the teeth hurt, and there's nothing wrong with the teeth. It's just referred pain. I had a very good dentist that actually was very knowledgeable about ME and was telling me the importance of not having inflamed gums because that contributes to inflammation, which I thought was really interesting. That I went to a dentist who
Right.
was telling me about
Yeah.
how you improve your inflammation whatever levels by practicing good oral health, and how that's super important. And I was amazed, who knows and who doesn't.
Right. Right.
But yeah, I mean
Well, what I was trying to bring out there, and not in your situation, but some patients, some younger women, for instance, worried about childbirth, child delivery, what impact will that have on their ME? So I was going with what other procedures that you might have to have medically, how do they impact your ability to be resilient, and kind of return to at least your old baseline? So that's another issue. Yeah.
but all medical procedures, especially anything that's invasive, for someone, I mean, they're disagreeable for all, but then just the going to the doctor and then, lying down, and then there's the pain amplification aspect of it. So that's why when I was referred, let's say for the interstitial cystitis, they wanted to do all of these very aggressive tests, and I'm like, please don't do them because the likelihood then is that I'm going to take three weeks to recover from your tests,
Right.
and these
Right.
tests are not going to reveal anything. Oh,
That's
but we have to rule it out. And I was like, well, why don't you look at this article here that says this is common? Oh, but for us to get that diagnosis, we have to rule out everything else, and so you have to have this and this and this. So I end up, not getting the exams.
right.
So
Yeah.
so yeah, medical procedures take an
Medical
inordinate
procedure.
amount of
Yeah.
blood.
And the last question or two, how important, let's say you get referred, somebody decides, or some kind of, conditioning thing. Do you think it's important for physical therapists in Portugal to have some knowledge about this illness and even teach the patients how to pace? Because normally when you go to physical therapists, they're pushing you to run, run, run. But
Absolutely, and I do try and do physical therapy. I've had a some physical therapists that won't let go of the CBT and the GET. That is so ingrained. It's so ingrained, and
Right,
they confuse ME with fibromyalgia. So they have these exercise programs for fibromyalgia that they're very gung-ho on, and I try to explain that I can't. And then when I do, I pay the price. So
Yes.
I'm still looking for a physical
That kind of
therapist.
thing. Right. Yeah.
But
And
yes, definitely we do need to learn about this as
right. Yeah. So if you had to say your one biggest hope for your effort here is to teach primary care doctors how to identify it initially, and then maybe to train younger people in this field.
For patients to understand that we have a lot of patients on board, that some of the symptoms that may be a little out of the ordinary actually relate to ME. And so when they go see their doctors, that they don't, that they ask for, an examination that isn't cursory, but that really is in depth and takes into account these myriad other conditions. Because some of these myriad other conditions, we can do symptom relief, and treat the various problems. And so little by little, you fix this a little, you fix that a little, you fix that a little, and then you go up one step in the ladder towards better health.
I think another quick common misconception is sometimes the physical exam on ME people can be completely normal and you look fine, looking at you, you look great. And so I call it the invisible illness. So sometimes, and this is very common with the disability doctors that examine, her physical exam was fine. She's fine. She can go to work, so be very cognizant to listen to the patient, like you said, the magnitude of the patient's symptoms, the effect on their daily living. And then the laboratory tests help a lot, doing the right laboratory tests to help support the diagnosis. But it's one of those diseases where there aren't many physical findings. So I think a lot of doctors find it a little disruptive to their normal practice.
Right. And they say that it's psychological,
right.
or that you're depressed or whatever.
No, I mean, you're a go-getter. You're somebody who, I know you, but even when I met you, I think you have to assess that person. You had years of traveling, like you say, and helping people. I mean, why would you make something like this up? It's just ridiculous. Anyway, I try to take into account the patient. So you're somebody that, and many of patients are people who had so many things, such an agenda for their lives. Like, why would they, not pursue it if they could? Anyway.
Levine, just one question, because we have some mothers in the group, and I'm sure they're going to be asking questions. But how do you? Are there any differences in how you do intake with children, pediatric?
Yes and no. I mean, interestingly, and I didn't want to, get into too many other topics while we were talking, but that's why I brought up about the cardiology. Frequently, if I see, and I do see some children and adolescents, they will come in through the POTS back door, I call it. So they will first be diagnosed. So I have some cardiologists in New York even who, hey, you should see Dr. Levine because I think you have more than just POTS, or you have more than just migraine headaches. I think you have ME also. And so a lot of the kids get fainting spells at school or like doing sports, or have the rapid heart rate. So often the presentation is the dysautonomia part of it, the POTS, and some people with gastric dysmotility. And the other quick thing, hypermobility. Some of the kids who are gymnasts and have been hurt, I have ballet dancers who have dislocated a shoulder, and lo and behold, they get fatigued on top of that, and it's all been attributed just to the EDS or the hypermobility, but in fact, they may well have. So those other comorbid things precede their diagnosis more often in the adolescents than in the adults. It's kind of an interesting. I wish there were like that distinction, or that would be written about more in the literature, like adolescent presentation of ME.
Super. So I think we have some 10 minutes now for questions and answers. Anyone want to posit a question?
Can I ask you something, Dr. Levine? It's Patricia. I would like to ask you, when you are doing a first consultation and you have a patient with those 3 symptoms that for me are also very important.
Hi, sure.
Can you hear me?
Yes, no, I'm fine. No, good, good English. Go ahead. Yeah.
Sorry, because I'm going to turn off the light. Can you, when you had those patients that come for your consultation as adolescents or young adults, I can also share that people that have hypermobility, they tend to have more fatigue, they tend to have more muscle pain and more friction rubs in them tendons, and sometimes it's difficult to make the distinction with those. But for those patients that have those three, and you think for your clinical perspective that is an EM patient, do you have a basic lab profile that they should fulfill in this first consultation, or
Yes.
and then because when we are doing science medicine based, we will ask for the lab tests in a profile in the first consultation, and then we will enroll more tests if these were not positive, at least in the first consultation. This is my.
Yeah, go ahead.
What do you consider is more important? Because this is also a very important task that we can teach to our colleagues, is when you have a patient with fatigue, and I'm a rheumatologist, it's very common for me to see patients with fatigue and with pain, because I see a lot of fibromyalgic pain patients, or patients that have fibromyalgia and fatigue, but they don't have EM criteria. So it's of course that we should focus on those major exams to exclude some other diseases.
Right.
But for instance, in this topic, like because now we are beginning to use also methanol for these diseases, but we also have to think about myasthenia gravis, the light forms, and in a first consultation, will you ask for those antibodies, or you will only consider them if the clinical?
Think that because of the complexity of the illness and because the patient literally gets exhausted, I'm sure Joan is exhausted now, that I wish we could divide. I have the first appointment almost in 2 or 3 parts even. So what I usually do is I have kind of an intake form that I send in advance of the meeting as well. And sometimes the family members help to fill that out, then that helps. But no, you bring up some good points. So if I suspect that there is a neurological component, like the myasthenia, for instance, I would refer to a neurologist who I would refer them to perhaps anyway to rule out the small fiber neuropathy part. I probably wouldn't do the myasthenia antibodies in the initial visit, but we run things like the Epstein-Barr early antigen, the reactivation thing. And then, so one of the things I was suggesting to Joan is maybe in a separate series that we have like a grouping of like a profile for me. And that would include like immunoglobulin levels also, and some other things, mast cell components and so forth, cytokine levels. And but you're right, you have to make sure it's the degree. Those EDS patients, you're right, you can get fatigue, but if the fatigue becomes really out of proportion to their physical problem, then I start to worry about ME on top of that.
We have a question now, 2 questions from Monica. Monica, can you unmute?
Yes, hi.
Hi.
Hi, Dr. Levine.
Hey, how are you?
Great to see you.
Yes.
You referred to diagnostic tests. What would you, that's my first question, is what would you recommend for a patient who's had ME for 32 years?
Right. I'd be very happy, by the way, to put, write up a little something for you too. But basically, you want to make sure that the patient, within reason, has undergone the appropriate testing to rule out other possible overlapping disorders. I mentioned one, the adrenal insufficiency, the thyroid, obviously, rheumatoid arthritis, which I'm sure you know about, and lupus, and in our, probably not in Europe, but Lyme disease here in the US. do kind of a combo depending on what the patient has already sent me from their file. And if they've missed anything, in my opinion, then I'll include it in my workup. In addition to the Epstein-Barr profile, the mast cells, products, cytokines, and immunological kind of workup. I try to mostly do not so much ornamental blood tests, but ones that are actionable. So I could do like fancy T cell studies and things like that, but I find that they don't help me forward the treatment plan so much. And, you know, so I distinguish between the research level testing and the practical day-to-day testing for patient care. So, and I'd be very happy, and I think it would be a good idea, but I thought it might be too much to talk about it extensively on this particular segment.
Sure.
To write up like a thing that maybe you could put on the website as a suggestion for a CFS panel.
I look forward to hopefully booking an appointment with you in the very near future.
All right, hon.
My second question is, what is the relevance of a history of a severe automobile accident? You asked in the beginning.
Yes, I think that's important. It's also, well, in fibromyalgia, that's often an association that it can trigger it. But we find that automobile accidents and concussions involving the head, obviously, for some crazy reason, that in certain individuals can trigger ME. We think of it as just mostly viral, and mostly it is, but postpartum, after a lady gives birth, menopause, something called Graves' disease, which is a thyroid treatment, and a car accident or severe traumatic injury can do something to your immune system to catapult you into having ME in those genetically susceptible people. It's not well understood yet. But
okay, thank you.
And we have another question from Andre. Andre, can you unmute? Andre?
I'm here. Can you listen to
Hi
me?
there.
Hello.
Yes.
Hello again. Yeah, yes, I have a question. Since post-noise exercise is somewhat vague, we'll say it's vague. What tests, for instance, or exams can be done so we can prove to doctors that we have objectively that symptom, that it exists?
Well, you're absolutely right. I think, as Joan was pointing out, that you guys are developing these, and having available access to these CPET testing facilities. Some people complain, some patients, that doing the test itself will cause a terrible relapse. So I tend to not run it on every patient, especially if they're in a fragile state. And I guess being kind of an expert in this area, I can judge, when a patient tells me that walking the dog or going to the supermarket is enough to have them lay in bed for a day or two, I'm kind of satisfied. I mean, I'm sure they're not, fudging on that one and making it up. So I kind of try to say, like, what activities, going out to dinner with friends on top of your regular day job, like weird things that we normally should be able to withstand without an issue. If that catapults you into a crash, to me, that's a kind of a substitute, although I know it's a soft, kind of not super objective way of determining that. But, once I'm pretty certain, based on other criteria, that the person definitely has ME, I don't question that too much. So I don't necessarily push them to do that testing. Some doctors, I'll just say very briefly, have this thing in the office where they make them go up and down some steps and then see where their heart rate has gone in a minute's time. There's like some shortcuts to determining that, like, objectively, but it's tough because mostly the patients will suffer if you do the full real test, like the CPET.
Thank you. Yes. I
Fortunately,
understand.
for me, I did the 2-day CPET and the ICPET because in order to prove functional disability, you need to have these quantitative indicators with tests that no one can say, oh, you just have a physician, who's very sympathetic.
Right, that's right. Yes.
So I think the ability now to have that ICPET in Portugal is enormous, and that's something that we've been working for under Millions Missing Aliança now. And the second is to have the 2-day CPET be available in the public system. That's something that we're discussing as well, figuring out ways, because right now you can do one, but you don't get to do the 2-day. That's something it's an achievable goal, I think, within the public system, and the other, and then to try, to really work on having public sector responses, because that's where the majority of people go for care. Not everybody has private health insurance, and you know, if you lose your job. Can you elaborate on hypermetabolism, cardiac problems, cholesterol, insulin?
Sure, sure. So it's actually the opposite. It's hypometabolism. I'm sorry, I didn't say it clearly. So it's a kind of a newish field, but as Joan also mentioned in the brief introduction of me, I'm part of this group at Columbia that's studying proteomics, genomics, and metabolomics in ME patients. And what that means in plain English is the body doesn't rid itself of fuel as efficiently as it should, because it perceives that you're in a low energy state. So in a way, you kind of accumulate this excess fat, so to speak, and insulin levels, because it's like you're a bear hibernating for winter.
Oh yeah, like the hibernating bear. They get really fat. Yeah, I can imagine that.
And where a lot of people, even obviously you're not exercising, but feel that they put on or have a hard have a harder time losing weight, because the metabolism is in this conservation mode. And it's a complicated explanation, but there's these lipoprotein molecules that we feel are not excreting the fat, the bad fat, as they should. And so you may be later on in life at higher risk for cardiovascular. So interestingly, with long COVID, some people actually treat with atorvastatin, because cholesterol and a lot of these molecules are actually inflammatory molecules. So normally one wouldn't think that treating somebody's high cholesterol would help with their fatigue, but because it may contribute to inflammation, people are using atorvastatin, which is a statin, it lowers cholesterol, and then metformin, which is a drug that's used in prediabetes, to help regulate the insulin better. So it's interesting how metabolic things are coming into play. And I'm trying to learn more about it in my old age, like amino acid levels is another field I'm sort of tinkering with, by measuring levels of amino acids in patients. And by fixing them, can we help that patient's fatigue? But it's definitely an interesting area, because so many body systems are affected with this illness. Serotonin levels, for instance, are also depleted. And so, like, I can't think of a body part that isn't impacted by ME.
Sure. Thank you so much, Dr. Levine. Thank you, Joan, and thank you, Benny. It's been so amazing, so illuminating. Thank you.
Thank you
Thank
all.
you.
Thank you all for participating, and I hope you will be regulars in our monthly Zoom conversations. We have the next one we can announce today is going to be on the 27th with Dr. Patricia Pinto and Dr. Jaime Branco. That'll be the next topic, and then we'll be bringing Dr. Levine back and many other specialists that have agreed to help us in this process. And so,
Right.
Benny, do you want to say some last words as a coordinator?
I want to say goodbye, everyone, and special Dr. Levine, and say thank you very much.
I enjoyed this very much. Thanks for your big effort. Thank you, guys.
Thank you for your time. You really are. You're really great.
Thank you. You too, Joan. Thank you. Nice talking to you guys.